So now we're going to discuss tennis elbow or lateral epicondylitis. Although it has itis in the name, which suggests some inflammation, there isn't really an inflammatory cause for lateral epicondylitis. The histology suggests micro tears or micro injuries and poor healing, therefore fibrogen disarray and lots of new vessel formation. And therefore, although we do treat it with injections that for some reason settle it down, it often is something that we need to rest and treat with physiotherapy to give the best results and long-standing results. If I can just take the arm here, the area we're looking at for lateral epicondylitis is around the common extensor origin. Therefore, if you place your finger over the triceps at the back, come round, and the first bony prominence you feel is the lateral epicondyle of the humerus. The common extensor origin here has extensor carpi radialis brevis, which is the deepest, extensor digitorum communis, ECU and EDM. And these will then fan out over the rest of the arm. The area which usually is most painful, and it usually affects ECRB, extensor carpi radialis brevis, is around 1 centimetre or 2 distal to this lateral epicondyle. If you're feeling it on yourself and you're wondering whether you're quite in the right position, it also happens to sit over the radial head. And therefore, if you hold the patient's hand and supinate and pronate at the same time, then you'll feel the radial head moving under your thumb. That's usually then the right area for the maximal tenderness. For working through your look, feel, move, looking in this area, now you know the surface anatomy and where the problem usually is. You'll be looking for signs of previous injections, so thinning of the skin from a steroid injection, or thinning of the fat, and also hypopigmentation. The final thing to look for in lateral epicondylitis is scars, and therefore the potential scar of an operation if this is a recurrent problem. The scar is usually over the radial head or the area of tenderness that we've been describing, and it can be longitudinal, which then splits the muscles, or more commonly oblique, just over the side of the radial head. Usually there's not many other signs to look for. To feel, as I've suggested, around 1 to 2 centimetres distal to the lateral epicondyle, it's often tender, and then moving and special test is really where you isolate the pain. So movement, if you ask the patient to flex fully, it can elicit pain in this area. And on wrist extension, usually it doesn't cause too much problems unless it's resisted. The special tests to isolate this are Mills test. So Mills test is for the patient to actively flex and then to push further, but with the elbow fully extended. If the elbow is flexed, the muscle is slightly relaxed because it crosses the elbow joint going to the humerus. Therefore, if you extend the elbow and hyperflex the wrist, it stretches that muscle fully. You then have Cozen's test, which is resisted wrist extension. For this, you do flex the elbow to around 90 degrees. And if you place your fingers over the second and third metacarpal and ask the patient to bend their wrist back or extend, you don't want them to come all the way back to here, but more just you're resisting them in a slight extension, but on the radial side. And this again should cause pain in this region. And then finally, Maudsley's test, which is more focusing on the extensor digitorum communis rather than the ECRB, is often done with a hand flat on the table. And because you're trying to stretch or strain the EDC, you use the middle finger and ask the patient to lift the finger off the table. And then if you press down over the P2 or middle phalanx, this then strains the EDC, and if that's the problematic muscle, can cause pain in the same site. So now we're looking at Dequervains tenosynovitis, and what this is where the extensor pollicis brevis and abductor pollicis longus tendons run across the wrist in the extensor retinaculum. There is thickening of either tendon or the extensor retinaculum, causing entrapment and pain at this level. The surface anatomy for this is, again, feeling the radial styloid, And it's usually around 1 centimetre to 1.5 centimetres proximal to the tip of the radial styloid, where the tendons are sitting very much on the radial side of the radius. Although it is called a synovitis, it's again not an inflammatory condition similar to the lateral epicondylitis, and it's more myxoid degeneration that you get around the tendons rather than an inflammatory problem. You're looking very much like with the tennis elbow, you're looking for signs of steroid injections, because this often is a treatment and it can be superficial, and therefore depigmentation, which can actually work all the way up the tendon and can give you a white line in the line of the APL or EPB. Thinning of the skin in this area, or you can have marked swelling in some cases when it's quite severe and inflamed. So when looking for Dequervains tenosynovitis, often there's not much to see. You can have swelling in the area of the first extensor compartment, just proximal to the radial styloid. There can be signs of previous injections, such as thinned fat or depigmentation in the line of the tendons. There may be scars from previous surgery if it's a recurrent problem, and the scars can be longitudinal over the extensor compartment, just dorsal or palmar to that, or often many people perform a transverse incision over this area. There can be marked swelling there, and when you're palpating it can be very, very painful, and therefore you need to be aware with the patient, one, that you're going to press that area to isolate where the pain is, but also that it can be quite uncomfortable. And so for palpation or feeling, it's feeling in this area, and you can work your way along the radius until you find the tender point. At this point you can also feel some crepitus, and although it's an overlap between some feel and move, if you ask the patient to wiggle their thumb, then you can feel more crepitus if there's tethering within the first extensor compartment. For move of the Dequervains tenosynovitis, it's often about ulnar deviating the wrist and flexing the thumb into the palm. And so simply you can ask the patient to ulnar deviate the wrist and see if it causes pain there, and then you can ask them to put the thumb into their palm. To exacerbate these, very similar to this, are the two tests. One is Finkelstein's and the second is Eichhoff's, and they're often mixed up or overlapped. Finkelstein's test is the examiner taking the patient's thumb and sharply pulling it down into ulnar deviation and flexion, and it causes pain along this area. Whereas Eichhoff's test is asking the patient to put their thumb into a fist and then the examiner bending the wrist into ulnar deviation, both of which should cause pain here. Finkelstein's tends to be more sensitive and specific.